subgroup. Females had a slight preponderance.
Illumination defects in the pupillary margins, poor pupillary dilatation, heterochromia iris. The involved eye is myotic, it has weak zonules. The patient was done with slit lamp examination, intraocular pressure, gonioscopy and optic nerve head examination. Presence of pseudoexfoliation is also associated with increased risk of zonular dehiscence, capsular rupture and vitreous loss during cataract extraction. This is a cross-sectional study which was done in all the patients who are attending with visual complaints in the ophthalmology OPD. It was done over 50 patients with visual complaints and the study duration is of 18 months. Inclusion criteria includes patients of East Godavari district who are attending the ophthalmology OPD above 50 years of age, and exclusion criteria involves patients who are having previous history of trauma, anterior uveitis and known cases of glaucoma. In these patients, following things were looked like in conjunctiva, congestion, cornea, edema, pigmentation, deposition of any exfoliation material, pigment dispersion. In iris, the pattern, transillumination defect, iridodonosis. For pupil size, reaction to light, exfoliation material, dilatation with mydriasis, and in lens, exfoliation material deposition, the cataract type, phacodonosis, subluxation or dislocation of the lens were noted. Fundus examination was done with direct ophthalmoscope and slit lamp biomicroscopy to look for glaucomatous change, and if the patient underwent cataract surgery, the proper investigations were done. Pre-op preparation of the patients were done on a routine basis, and post-operatively all patients received topical antibiotic steroid eye drops and which were tapered over week. Follow-up of the patients were done following cataract surgery up to 6 months and initially weekly for 2 weeks, which include anterior segment examination, IOP and fundus examination. Patients who had no evidence of glaucoma were advised yearly follow-up, and patients with glaucoma underwent Follow-up for every 3 to 6 months depending upon their IOP and optic nerve head status. This is the pictures which shows the pupillary rough defect and the deposition of the exfoliation material around the pupillary margin. And this is the picture of the gonioscopy which shows the pigmentation over the trabecular meshwork. In the results and observation according to the age distribution, maximum incidences of pseudoexfoliation that was noted in the age group of 61 to 70 years of age. According to the sex distribution, most of the cases were male, that is 66%. 74% cases had bilateral preponderance of pseudoexfoliation. Association of glaucoma, 48%, that is 24 out of 50 patients had association with that of glaucoma. Out of the 48% of the glaucoma patient, open angle incidence was more, that is 66.66%. Optic nerve head damage was considered, and seeing that open angle cases, they had no damage in 8 of the patient and late damage was found in 5 of the patient. This is the bar diagram which shows the incidences of the nerve damage in open angle and the closed angle cases. The other clinical features found in pseudoexfoliation patients were in conjunctiva pterygium, cornea, pigmentation, anterior chamber exfoliation and the presence of any membrane, iris, pupillary rough defect and iridodonosis. Pupil, it was noted for poor pupillary dilatation and deposition of exfoliation material. The surgical complications which were underwent during cataract surgery were corneal endothelial loss, difficulty in nuclear delivery, zonular dehiscence, posterior capsular rent, vitreous loss, and post-op iritis was also found. Most of the cases were implanted with posterior chamber intraocular lens, but in patients who underwent complications, scleral fixated IOL were kept, and some patients were kept aphakic and referred to in a higher center. Association of complications in cataract surgery in pupillary diameter, it is shown that most of the patients who had pupil less than 6 mm in size underwent more complications. Post-operative visual acuity of most of the patients was in the range of 6/60 to 6/18 following first week and 1 month follow-up. So in discussion, 50 cases of pseudoexfoliation syndrome which came to our hospital, they were analyzed for features of pseudoexfoliation, association with glaucoma and the surgical complications. Most of the patients were in the age group of 61 to 70 years, 66% were male and most had bilateral preponderance of 74%. 48% has association with glaucoma and most of the cases, that is 66%, were open angle cases. So in conclusion of my study, maximum incidence is at 61 to 70 years of age with a median incidence of 63.71 year. Pseudoexfoliation is a significant risk factor for development of glaucoma. Poor pupillary dilatation is one of the major preoperative risk factor which has an impact on the intraoperative complications during cataract surgery. Complications include corneal endothelial touch, zonular dehiscence and posterior capsule rent. Adequate modification like sphincterectomy, synecholysis, pupil stretching technique should be done in eyes with poor pupillary dilatation to reduce the intraoperative complication. Due to its fluctuating IOP, aggressive course and difficulty in managing with medical treatment, pseudoexfoliation stands as a distinct enigmatic clinical entity. So pseudoexfoliation needs early detection, regular follow-up and definitive therapy. Thank you.
First slide, please. Your inclusion criteria for pseudoexfoliation. See here, you have mentioned as open angle closure.
Yes.
You have not mentioned gonioscopy anywhere as part of evaluation. So how did you come to a conclusion it's open angle or angle closure?
It was done. Gonioscopy did, sir. Depending on that,
But it has not been mentioned in their inclusion criteria. And you have never done any stereoscopic evaluation of the optic nerve head.
No,
it's always direct ophthalmoscopy.
Just slit lamp biomicroscopy and direct ophthalmoscopy with it.
So
do you think gonioscopy is important?
Yes, madam. There will be a lot of differential diagnosis that can come when we are making a diagnosis of any secondary glaucoma in this patient. So we should make sure that it is not a pigment dispersion. We should also look at whether it's an open angle or it's a closed angle. And also we should look for the pigment deposition and depending on the management also, the management pattern will also differ, madam, depending on whether it's an open angle or it's a closed angle. So before proceeding for the treatment, we should do a gonioscopic examination.
So you have to include gonioscopy also in your inclusion criteria. Good.
Thank you.
Okay, then D. Sai Divya Reddy.
Good morning to all the delegates. Myself, Sai Divya. Today, my paper topic is Study to Determine Prevalence of Primary Open-Angle Glaucoma in Patients with Systemic Hypertension. Introduction. Glaucoma is a chronic progressive optic neuropathy characterized by recognizable patterns of alterations in the structure of optic nerve head and nerve fiber layer of retina and consequent visual field defects. It is the leading cause of irreversible blindness worldwide, second only to cataract, accounting for 14% of global blindness. And India accounts for 23.5% of global blindness, with 12.9% of primary open-angle glaucomatous blindness in the world. Globally, primary open-angle glaucoma affects more people than primary angle closure glaucoma, with an approximate ratio of 3:1. Risk and prognosis of primary open-angle glaucoma is influenced by demographic factors such as age, race, and family history, and by several ocular parameters including myopic refractive error, optic disc shape, and corneal thickness, systemic factors like blood pressure and diabetes. Increased intraocular pressure is the most important modifiable risk factor for POAG. Evaluation of hypertension as a risk factor for POAG in our population is essential so that the disease can be detected at an early stage by screening these high-risk groups. Aim to find the prevalence of primary open-angle glaucoma in patients with systemic hypertension. Materials and methods. A cross-sectional case control study was conducted from November 2022 to April 2023. Cases are subjects with primary hypertension and controls are age and sex matched subjects without hypertension. Patients underwent detailed ocular examination including IOP and blood pressure measurements, followed by perimetry gonioscopy using Goldman's 3 mirrors done for all subjects with IOP more than 21 millimeters of mercury or cup disc ratio greater than or equal to 0.5 or asymmetry greater than 0.2. My inclusion criteria are patients with documented systemic hypertension on antihypertensive medications, patients above 40 years and age-matched non-hypertensive controls. Exclusion criteria are patients less than 40 years of age with secondary glaucomas and patients with diabetes and with known family history and any corneal scarring or opacity on which gonioscopy can't be done, and previous ocular trauma or diseases other than primary open-angle glaucoma. My results are age distribution of study subjects. Mean age of subjects with hypertension was 57.94 years, and in non-hypertensive group it was 57.55. And age distribution of glaucoma patients, mean age of patients with glaucoma was 63 years. And gender distribution of study subjects, females were more with accounting to 55%. And in POAG patients, in hypertensive group, 3 were males and 2 were females, and in non-hypertensive group, 2 were males and 1 were female. And blood pressure in patients with POAG, in hypertensive group, blood pressure we had was 143.11 out of 88.9 mmHg, and in non-hypertensive group, mean blood pressure was 115 out of 75 millimeters of mercury. And blood pressure in patients without primary open-angle glaucoma, in hypertensive group it was 138 out of 88 millimeters mercury, and in non-hypertensive group it was 116 out of 74 millimeters of mercury. And duration of hypertension, most of them were had hypertension for a duration of 1 to 5 years with 17, next come 5 to 10 years, and less than 1 year, and the least was more than or equal to 10 years. And duration of hypertension and primary open-angle glaucoma, out of 5 patients with glaucoma in hypertensive group, 60%, that is 3 out of 5 were hypertensive for more than or equal to 10 years. And mean IOP in hypertensive group was 17.30 plus or minus 3.268, and in control group it was 16.02 plus or minus 3.250. And intraocular pressure and glaucoma, there were 8 patients with primary open-angle glaucoma. And prevalence of glaucoma, we have 5 POAG cases with hypertension and 3 were without hypertension, contributing total of 8 out of 100 patients of total subjects. And discussion, out of 100 subjects studied, 8 of them were found to have glaucoma, amounting to an overall prevalence rate of 8%. Percentage of prevalence in hypertensive group was 10%, and in non-hypertensive group it was 6%. Among 8 patients with POAG, 37.5, that is 3 out of 8, were below 60 years of age, and 62.5, that is 5 out of 8, were above 60 years of age, which suggests that Occurrence of POAG increases with increasing age. There was statistically significant difference in the mean intraocular pressure of hypertensive subjects when compared to non-hypertensive subjects in our study, with IOP of hypertensive patients being higher. Conclusion: results are insignificant to consider systemic hypertension as an independent risk factor for glaucoma, and persons with longer duration of hypertension and advancing age need to be monitored for high intraocular pressure and optic nerve head changes to aid in early diagnosis and minimize visual morbidity and blindness due to glaucoma. These are my references. Thank you.
What is the criteria to say open angle glaucoma?
Sir,
What are investigations you have done to confirm a case as open angle glaucoma?
Sir, I went with measurement of intraocular pressure by Goldman applanation, and I've seen the fundus, sir, and I've done gonioscopy.
You have not done a visual field analysis?
Yes, after that I've sent for visual field
It's not
analysis.
in your slide. There is no mention of visual field analysis.
Yes, sir.
So how did you come to a conclusion that it's a case of primary hypertension? Your slide, please. Were you in consultation with a general physician to say it's a primary hypertension?
Yes, sir. I've combined with done with the general medicine. I've coordinated with them, and I've took cases from.
So
there.
did you rule out those cases of secondary hypertension?
Yes, sir.
You have done or the physician has done?
No, they've given me just the case. For cases, I've coordinated with them, sir.
So you have gone to a general medicine department, picked out 100 patients from there, and you brought them to your OPD and did glaucoma checkup for them. How I did not understand actually from your presentation.
Yes, I had coordination with the general medicine people, ma'am, and I took the cases from there and have evaluated for this intraocular pressure and fundus changes followed by gonioscopy.
So
and for
randomly you picked up. How did you pick up only those 100?
like during this study period, I've.
So every day you were going to general
Yes,
medicine
ma'am.
and what is the definition of hypertension in your study? And how was the BP measured?
Manually, it was measured, ma'am.
Do you have any standard way of measuring BP if you are doing such a study? Is it first time or how many readings have you taken?
3 readings, ma'am.
Is it mentioned anywhere in your paper?
No, ma'am.
So most important thing is you have to define hypertension when you are talking about glaucoma in hypertension.
Okay, ma'am.
And you have not mentioned anywhere that it was conducted in coordinates with some general medicine department or anything. So first and foremost you have to define what is hypertension, what is the systolic BP, what is the diastolic BP which you have taken, how many readings you have taken, what is the measurement, like how you have taken it, whether it was done in sitting position or lying down position, who has taken it, is it always one person has taken, is there any inter-observer variability?
No, ma'am. Only one person, ma'am.
Always one person with the same BP machine?
Yes, ma'am.
So all that should be included.
Okay.
You have not defined what is hypertension in the study of what is important here. You have not done that. Yeah.
Thank you.
The next presenter is Dr. N. Lakshmi Priyanka.
My name is Priyanka, second year postgraduate. Now I am going to tell a series of cases regarding the correlation of retinal nerve fiber layer thickness with visual field defects in patients with primary open angle glaucoma. My aim is to study the correlation of the retinal nerve fiber layer thickness with that of the visual fields in patients with primary open angle glaucoma. Inclusion and exclusion criteria. Inclusions, we have included all the cases of primary open angle glaucoma, and exclusions, we have excluded the patients with media opacity, history of retinal diseases including a diabetic, hypertensive or CKD, and best corrected visual acuity worse than 6/24, and history of any eye trauma or surgery, and neurological field defects that affect the visual fields, and unreliable visual fields and poor OCT images. And we have also excluded the angle closure glaucoma and congenital glaucomas. Materials and methods. 50 patients attending the ophthalmology OPD NRIGH Chinnakakani with primary open angle glaucoma were included in this study. Institutional ethical clearance and the informed consent was taken. It is a prospective type of study, and detailed history and ocular examination was done, and history regarding the family history of glaucoma is also taken, and visual acuity regarding the is done with the Snellen's chart, and anterior segment examination with slit lamp biomicroscopy, and IOP was done by applanation tonometer, and angle by gonioscopy, and posterior segment we have done either with direct ophthalmoscopy or indirect ophthalmoscopy or with slit lamp biomicroscopy with 90D lens, and a standard automated perimetry, that is Humphrey static perimetry of 30-2 was performed in all the cases to detect the visual field defects, and SDOCT, that is spectral domain OCT, was done for measuring the retinal nerve fiber layer thickness. Age distribution, most of the patients lies between 18 to 73 years, and maximum of which lies between 40 to 50 years, that is 12 patients. And gender distribution, out of 50 patients, 32 are females and 18 are males. Family history, there is a 10 cases showing a family history of known cases of glaucoma, that is 20%, of which 6 are females and 4 are males. Baseline IOP measurement, maximum ranges between 10 to 20 mm Hg, that is 60%, followed by 20 to 30 mm Hg and followed by 30 mm Hg. Visual field defects, normal is 8%, and paracentral scotoma is seen in 60%, arcuate scotoma in 12%, and double arcuate in 2%, and tubular vision in 2%, and general reduction in sensitivity in 16%. RNFL defects, normal is seen in 22%, and superior defects we have seen maximum, of which they are 24%, inferior defects are 18%, and superior and inferior defects are 20%, superior and temporal are 7%, inferior and temporal are 3%, and least is the temporal defect, that is 1%, and combined defect of superior, inferior or temporal we have seen are 5%. Out of the 50 cases, 40 cases we have seen the correlation, that is 80%. Out of 5 cases with superior arcuate visual field defects, there shows an inferior RNFL defect, and out of 9 cases with inferior arcuate defect, there shows a superior quadrant defect, and out of 2 cases with double arcuate in the visual field shows inferior RNFL defect, and out of 1 case with the tubular vision in the visual field defects shows either both superior, inferior and temporal defects. In 23 cases with the visual field defects of paracentral scotoma, there may be either superior, inferior or temporal defects. This is the image showing a visual field and a OCT of the same patient with the same eye, and in the visual fields we can see there is absolutely normal, and in case of the OCT we can see a inferior quadrant defect. And this is the image showing a visual field and OCT of the same patient with the same eye, which is showing a paracentral scotomas in case of a visual fields, and in case of a OCT it is showing superior defect. And this is the image of patient with the same eye and same patient with showing a arcuate defect in the visual fields, and in case of a OCT we can see a superior and a nasal defect. This is the image showing a visual field of the patient showing a tubular vision, and in case of an OCT we can see both the superior and the inferior defects. Discussion. In our study, the highest RNFL defect is seen in inferior quadrant followed by superior, nasal and temporal quadrants. Similar results were found by the Bird et al. Subba et al., while analyzing the results glaucoma patients, glaucoma suspect and of normal subjects using OCT, found that RNFL thickness was greatest in superior and inferior quadrants, which is also seen in our study. Conclusion. Retinal nerve fiber layer abnormalities can be detected by the optical coherence tomography, and it is compared with the visual field defects, which helps in the early diagnosis of glaucoma, even before the onset of structural damage. Early detection by the OCT helps to prevent the permanent vision loss by the visual fields before the visual is as defected, as 40% of the nerve fiber damage has already occurred. These are my references. Thank you.
What are the reliability indices which you have taken to take your visual fields in the study? Is it mentioned in your presentation?
No, madam, but I have taken the fixation losses, any false positives or false negatives. I have included those. As in the exclusion criteria, I have excluded the unreliable visual fields.
What do you mean by unreliable visual fields?
Whether there is any fixation loss, if it is more than 20%, we have excluded it. false positives and false negatives more than 33%, we have excluded it. And visual field index, we have excluded if it is not 100%.
What?
Visual field index.
Visual field index not 100. In any glaucoma patient, visual field index will not be 100%.
Sorry, ma'am.
What do you mean by poor OCT? You said you excluded poor OCT image. What do you mean by that?
While doing the OCT with the media opacities,
So
Well-
what is the parameter?
signal strength also.
Have you mentioned below what signal strength you have excluded your OCT?
No, madam, I haven't.
So do you
mentioned.
think it is important in such a study
Yes,
where
ma'am.
you have not mentioned the exclusion criteria? You cannot take all 100 visual fields you have done into study. There will be some. And have you taken the first field? Is there any learning curve? Was the field repeated?
Yes, ma'am. The fields are repeated if the patients are not cooperative, or if the patients cannot do, we have repeated the fields, and we also have repeated the OCT images also if there is any signal strength less.
So all that should have come up in your methodology.
Yes.
Why did you include visual acuity less than 6 by 24 in your inclusion criteria? Do you think that is important in
Yes,
glaucoma?
madam.
Explain.
Because in case of an in case of a glaucoma, even the patient may have a 6/6 of vision, tubular vision. Patient may have a tubular vision, but patient's visual acuity is 6/6, and patient does not think that he has any damage. So I have included those less than 6 by 24.
Okay. And can you see the disc clearly with indirect ophthalmoscopy? Can you make out the disc changes with indirect ophthalmoscopy?
Not completely, madam. I have used either direct or indirect, or I have used a slit lamp with 90D. Everything I have tried. Thank you.
Dr. M. Meher Divya.
Good morning, everyone. Myself, M. Divya Geeta, second year postgraduate from GEMS. I'm going to present a paper on clinical study of lens-induced glaucoma at GEMS Hospital, Ragolu. Financial disclosure and no conflicts of interest. Lens-induced glaucoma, it was first described in the year 1900 by Gifford and Vondiers, independent of each other. While the former described it as glaucoma associated with hypermature cataract, and later described it as glaucoma associated with spontaneous absorption of lens substance through intact capsule. It is a common entity presenting to the outpatient department as an acute painful diminution of vision with red eye. Late reporting for treatment of cataract has led to serious complications like LIG. It remains one of the most important cause of irreversible vision loss in rural areas. This preventable and curable condition, though rare in developed countries, it is unfortunately still prevalent in India. It is a clinical condition characterized by a secondary glaucoma in one eye with senile mature cataract or hypomature senile cataract or immature senile cataract with an open angle, and normal intraocular pressure and open angle in the other eye, and a prompt relief from symptoms and restoration of vision after cataract extraction in the affected eye. Based on the pathogenesis, it is further classified as open angle or lens protein related. There are phacolytic glaucoma, lens particle induced glaucoma, and phacoanaphylactic glaucoma, and closed angle or aqueous outflow obstruction, which is a phacomorphic glaucoma, and pupillary block glaucoma, which can be due to ectopia lentis. It may be congenital or acquired. The study emphasizes on the importance of early diagnosis, patient education, frequent and regular surveillance of all cases of cataract, which go for hypermaturity and early surgical intervention. Objective to study the demographics, clinical presentation, and management of lens-induced glaucoma. Materials and methods. It is a prospective study of 38 patients with LIG presented from September 2022 to May 23, who presented to ophthalmology OPD at GEMS Hospital. Inclusion criteria: patients presenting with phacomorphic glaucoma, phacolytic glaucoma, lens particle glaucoma, and phacoanaphylactic uveitis with secondary glaucoma, and glaucoma secondary to ectopia lentis. Exclusion criteria: cases of primary glaucoma associated with cataract. Methodology: detailed history and thorough ocular examination using slit lamp was done in 38 patients, and IOP was recorded by applanation tonometry. After intraocular pressure control done with medical management, gonioscopy done, and surgical management was planned according to the need. Prognosis was explained to the patient, and surgery was done after taking the consent of the patient. Postoperative care was taken, and thorough postoperative evaluation of posterior segment was also done. All the results were statistically evaluated. Results: sex distribution among the 38 cases. Females were about 68% with high predominance and than males, which accounted for 32%. Age, maximum patients were from the age group of 70 to 80 years, about 45% of the cases. Youngest case in the study was 51 years old and the oldest was 81 years old. Duration of symptoms, main clinical symptoms were eye pain in 94.2% cases and redness in 85% of the cases, associated defective vision. Cases presented within first week are 55%, within second week are 26%, and more than 3 weeks are 18%. Status of the fellow eye. The fellow eye of the patient, 55% of the cases are pseudophakic, and in 26% it is with immature senile cataract, and in 16% it is mature cataract, and in 3% it is aphakia. Etiological diagnosis, about 74% of the cases of phacomorphic glaucoma and 21% of the cases of phacolytic glaucoma, and in 5% it is due to ectopia lentis. These are the images. First image is phacomorphic glaucoma, hypermature glaucoma cataract, and phacolytic glaucoma, and it is ectopia lentis due to anterior subluxated lens due to trauma. Intraocular pressure, most of the cases, highest percentage of 55% were noted in the range of 40 to 49. On immediate post-op and during discharge, IOP was recorded, and highest percentage were between 10 to 19 millimeters of mercury. Plan of management, after intraocular pressure control with medical management, surgical management was planned. In 63% of the cases, SSCS with PCIOL was done, and in 32% of the cases, cataract extraction combined with pars plana vitrectomy and SFIOL was done, and in 5% of the cases, combined procedure, that is cataract plus trabeculectomy was done. Visual acuity. On admission, most of the patients were HM positive to PL positive. On the day of the discharge, 53% of the cases were seen between 6/24 to 6/36, followed by 6/12 to 18 in 29% of the cases, and less than 6/16 18% of the cases. This drastic shift of visual acuity from HMs to PL positive to better than 6/60, 1/60 during the discharge was noted. When the patients came back for follow-up on 6th week, again improvement of vision was seen in majority of them. Discussion, allergy is a condition to be taken into account in our ophthalmic patients, especially in our rural area. In spite of easy availability of surgical facilities, cataract surgery being cost effective and rewarding surgery, many people are becoming blind due to lack of awareness. Illiterate, old and rural populations are the worst affected. In this study, female predominance is seen. Similar results were seen in Venkatesh Pragna et al. And Raghunandan Kothari et al. And phacomorphic glaucoma accounts for the highest percentage, which is seen in Venkatesh Pragna et al. And Raghunandan Kothari et al. And phacolytic glaucoma more seen in advanced stage, similar to Spector et al. And Zerzink et al. And IOP prior to surgery was high. Post-surgery, IOP was reduced in 81% of the cases, seen in Jacob et al. And Raghunandan et al. Visual outcome better than 6/36 in 82% of the cases in this study. And similar study results in Venkatesh Pragna, 59% of the cases had vision better than 6/18. This study, 13% of the patients got no visual improvement, only marginal improvement is seen in the vision after surgery. This was the group where there is a lag between development of symptoms and the reporting for treatment was the longest. Late reporting was emerged as important causes. And associated pathologies were also seen in cornea, involving cornea and corneal opacity, and macula, that is macular scar, was seen in a few cases. Conclusion, it is a vision-threatening disease presenting as a painful red eye. Most important cause of blindness, not only due to senile cataract, but also due to glaucomatous optic atrophy. Even after the advanced surgical techniques and immense efforts by National Program of Control of Blindness, lack of awareness in rural population and good vision in fellow eye, causing them to remain with cataract lens for a prolonged period. These are my references. Thank you.
Your inclusion criteria for lens-induced glaucoma. So here there is no mention of posterior segment evaluation. You already mentioned that 2% there was no vision recovery because of macular scar. There is no documentation of evaluation of the posterior segment in any of your cases. Especially subluxated lens, you can evaluate the posterior segment, isn't it?
Yes,
there is no mention of that. So an attempt should be made, even if in lens-induced glaucoma.
Yes.
B scan can be done.
Yes, sir.
To evaluate the posterior segment. Yes. So you have not recorded the IOP after the cataract surgery.
Recorded, sir.
You have recorded?
Yes, sir.
There was no mention of that.
Mentioned, sir. POD 1 and on discharge.
Can you go back to your criteria slide? Previous one. Previous slide. one. Previous one. So, is this how you defined LIG in your study?
Yes. It is a secondary glaucoma with.
No, you have read normal IOP with.
In the
open-
other eye, ma'am.
So, what about phacomorphic glaucoma?
Phacomorphic glaucoma, IOP is raised in the same eye. In
How will
present
the
eye.
angle be? Will it be open?
It will be shallow, closed, ma'am.
Shallow or what do you mean by shallow angle?
Shallow anterior chamber and angle will be closed.
So we cannot conclude all LIGs have open angles.
Okay.
Right? And on what basis did you do? Did you decide whether you had to do cataract or cataract plus trab?
Presentation, regarding presentation, and if there is a chronic presentation and presence of synechiae are present, then on after reduction of intraocular pressure, gonioscopy was done and angles were assessed, ma'am. On the gonioscopy findings, trab was done in few cases.
So when was the cataract done? After how many days after presentation?
After reduction of intraocular pressure, ma'am, within 2 days it was.
So the cornea cleared in 2 days and you have done gonio, and then you have decided whether you should do cataract or whether you should do cataract plus trab?
Yes, ma'am, in early presented cases.
So that should also have been included in your methodology.
Okay.
On what basis did you decide whether you should do only cataract or you have done a combined surgery?
Okay.
Okay, thank
Thank
you.
you.
Archita.
Good morning, everyone. Today's my topic of presentation is on a case series of glaucomatous optic atrophy. Glaucomatous optic atrophy can be characterized as an irreversible end-stage glaucomatous optic neuropathy with associated severe visual field loss and reduction of acuity. Clinically apparent is advanced optic disc optic cupping, loss of neuroretinal rim tissue, and optic pallor. This degree of optic neuropathy and functional visual loss can be secondary to various contributing factors, including an undiagnosed, poorly managed, or poorly controlled primary or secondary glaucoma. It is a retrospective study done in Department of Ophthalmology, Tertiary Care Center. Duration of study is 1 year. Sample sizes of 30 cases. Inclusion criteria: all known cases of glaucoma under treatment. Exclusion criteria is patient less than 40 years and optic atrophy due to other causes are excluded. Coming to patients, number of patients in 40 to 50 years are 3 patients, 50 to 60 are 16 patients, and above 60 are 11 patients. In total 30 cases, 16 were female and 14 were male. Visual acuity in affected eye, that is glaucomatous optic atrophy patient, it is ranged from no perception of light, hand movements, and counting fingers at 1 and 2 meters. Other eye, that is normal eye, visual acuity ranged from 6/24 to 6/9. Out of 30 cases, 16 patients have angle closure glaucoma and 14 patients have open angle glaucoma. Out of 30 cases, 18 patients are taking regular medication, in which progression of disease is ranged from 4 years to 15 years, and 12 patients are taking irregular medication. Progression of disease range from 3 years to 9 years. Out of 30 cases, 12 patients have a family history, 18 patients doesn't have a family history, and 20 patients have bilateral glaucomatous optic atrophy. 10 patients have unilateral. Fundus changes seen are in advanced cupping, with that is 0.9 to total cupping with disc pallor is seen in all patients. Other signs like bionating sign, laminar dot sign are seen in only 20 patients, and peripapillary atrophy is seen in 25 patients, and neuroretinal rim loss is seen in all patients. These are the pictures I have collected showing both eyes glaucomatous optic atrophy. This is the patient having tunnel vision with visual acuity 6/9 in both eyes. showing visual fields, tunnel vision, and glaucomatous optic atrophy. Discussion, a study of total 30 cases were examined, of which 16 were female and 14 were male. 12 patients are irregular medication and 18 patients are on regular medication, of which 12 having family history. In 30 cases, 20 patients having bilateral glaucomatous optic atrophy, 10 patients having unilateral glaucomatous optic atrophy. Predictive factors leading to progression found to be vary depending on the level of IOP during the course of disease. For patients with elevated intraocular pressure, significant predictive factors for eventual progression were older age, advanced perimetric damage, smaller neuroretinal rim, and large area of beta zone of parapapillary atrophy. Coming to conclusion, the development of end-stage glaucomatous optic atrophy leading to permanent visual loss is a disease process which may be proceeding at many levels. Certain ocular, genetic, and systemic conditions are most probably intertwined depending on the individual. The goal of therapy is to prevent progression and subsequent irreversible loss of vision. Therefore, a multidisciplinary approach for prevention, control, and management of the at-risk is mandatory. The importance of aggressive ocular treatment, proper diagnosis, compliance must not be underestimated. These are my references. Thank you.
When you say the patient has glaucomatous optic atrophy, what is the vision that you are expecting?
Hand movements to some patients having perception of light, some patients having no perception of light also.
Generally, if it is an optic atrophy, it is no perception of light. And how did you do fields for such patient?
Only for tunnel vision I have done.
Okay, then don't include that in this.
That's
no?
why I didn't include.
Okay, thank you.
Thank you.
Can you go back to your, what are the optic nerve head changes we expect in the case of glaucoma? Go back to that slide. What are the changes you have documented? This one.
Advanced cupping.
Okay. Now, in all of them, it was more than 0.9.
Yes, sir.
Any retinal nerve fiber layer defect?
Retinal nerve fiber layer defect I can't.
You did not document? Is it important?
Yes, sir.
Okay. Now, any absence or presence of splinter hemorrhages?
Splinter hemorrhages, mostly I didn't.
You did not see.
Yes, sir.
Okay. Can you go up to the very first slide? Your definition of, see, you again mentioned glaucomatous optic atrophy can be characterized as irreversible end-stage glaucomatous optic atrophy.
Neuropathy.
Okay. It is more of a optic nerve head changes, advanced optic nerve head changes. Anyway, thank you so much.
Thank you, sir. Thank you.
Okay, Niharika. Sorry, the last presenter is Dr. Rajesh.
Good morning, everyone present here. I'm Dr. Rajesh Kunanki. Today, I'll be presenting a paper on topic IOP monitoring pre-operatively and post-operatively, or observations at Dr. Perikushia Reddy Government Regional Eye Hospital, Colonel Medical College, Kurnool. Inflammation is a natural response to tissue damage due to cataract surgery, which can be damaging to the ocular environment. Steroids via any route inhibit production of leukotrienes and prostaglandins, thus decreasing the inflammation and hastening the recovery process and better visual outcomes. Steroids have significant side effects, and the most common complication being increase in intraocular pressure. Other risk factors that increase intraocular pressure include pre-existing glaucoma, advanced age, diabetes, high myopia, pseudoexfoliation, vitreous, residual cortex, or viscoelastics in the anterior chamber. Persistent elevation in intraocular pressure can lead to optic nerve damage and visual loss. Coming to the inclusion criteria, age 50 to 80 years were taken in consideration. Sex, both males and females were taken. Patients who underwent uneventful small incision cataract surgery or phacoemulsification. Exclusion criteria, patient who had previous history of glaucoma, patient with complicated cataracts and previous history of iridocyclitis, patient with complications during cataract surgery, patients already on corticosteroids, either topical or systemic, patients who have connective tissue disorders. Aim of this study is to evaluate IB fluctuations following cataract surgery with topical corticosteroids. This is the observational cross-section study of 200 patients conducted over a period of 3 months among patients attending the cataract OPD at REH Kurnool. All the patients were recorded by non-contact tonometer preoperatively compared with first day, first week, second week, fourth week, and 6th week post-operatively. Patients were given fixed topical eye drops with fixed drug combination of 0.3% citalfloxacin and 0.1% dexamethasone sodium phosphate for 6 weeks, and it was tapered weekly. High-risk patients were given NSAIDs eye drops after second week and lubricant eye drops in suspected dry eyes. The following parameters were assessed: fluctuation in intraocular pressure from baseline, difference in recorded IOP at different time period, age and sex, steroid response which was graded according to the rise in IOP from baseline conducted by Armali et al. Study. Low fluctuation in IOP was rise in IOP less than 6 millimeters of mercury. Medium fluctuation was rise in IOP by between 6 to 15 millimeters of mercury. High fluctuation greater than 15 millimeters of mercury. Coming to the results, in our study, we observed steroid-induced IOP elevation following topical steroids after 4 weeks post-op. The prevalence of steroid responders in our study was 9%, which was 18 patients. Mild rise was noted in 5.5%, which was 11 patients, and moderate rise was noted in 3.5%, which is 7 patients. None of the patients in our study had severe rise in IOP following topical steroid eye drops for 6 weeks. The highest mean IOP was noted at 4th week, being 23.5 millimeters of mercury, and second highest mean IOP was noted, which was 21.23 millimeters of mercury at first week follow-up, which is mostly due to post-op inflammatory reaction. Coming to the study, we have a higher number of males compared to females. Patients between 56 to 60 years are higher in our study. Now coming to the results, we have seen there is decrease in intraocular pressure by 1.03 millimeters of mercury on the first day, and there is subsequent rise at first week by 5.98 millimeters of mercury, and at fourth week by 8.27 millimeters of mercury from the baseline. This graph shows there is a peak at the first week and at the fourth week of the post-op follow-up. Coming to the discussion, the study done by Amali et al. Demonstrated that older adult population had higher risk of steroid-induced increase in IOP compared to the younger patients. But according to study conducted by Kusni et al., it demonstrated that there is statistically significant difference between there's no any statistical significant difference between the age group and the genders as compared to the IOP rise after surgery. According to the study conducted by Hongyu Dong et al., it demonstrated that topical steroid NSAIDs are equally efficacious when compared to topical steroids, and ophthalmologists should consider using 2-drug regimen in managing post-op cataract extraction. There's a paradigm shift in pharmacotherapy uncomplicated cataract surgery has deviated little from the norm, as indicated by the American Academy of Ophthalmology. Based on this current study and others, the authors believe that the pharmacological approach should be tailored to each patient. In our study, we observed there was a statistical significant difference, p-value being 0.03, in mean IOP between preoperative and with post-operative follow-up. The mean IOP on 4th week following cataracts was higher than the preoperative, which gradually decreased till 6th week follow-up. Coming to the shortcomings of our study, the sample size is small. IOP was measured with non-contact tonometer only. Comparison was not done between the patients undergoing SICS and the phacoemulsification. Surgeries were done by senior faculty and postgraduates. All the patients were put on fixed drug combination supplied at hospital and not compared with other steroid regimens. Coming to the conclusion, steroid-induced intraocular pressure elevation was observed mostly after 4 weeks of topical steroid therapy. The prevalence of steroid responders is relatively significant in our study sample, being 9%, thus coming to the conclusion that topical steroids should be used judiciously. Topical steroids should be tapered early and can be replaced or supplemented with topical NSAIDs and lubricant eye drops. In most cases, the IOP lowers spontaneously to the baseline within 2 weeks upon stopping the steroids. This small study highlights the need of IOP evaluation at every post-op follow-up and the need for alternative, safe post-op treatment regimens. Thank you.
Thank you. Thank you, everyone. This concludes the session. Sorry that we took more time. In patients where NCT was more than 20, did you try doing applanation tonometry, or you just went with the NCT? That's why you have given it as a shortcoming. Okay.
Where the IOP was high, did you put them on any anti-glaucoma medication?
No, sir, we did. We stopped that drug and we did. Is there any subsequent decrease in the IOP in the following weeks? So that there was no subsequent decrease in the IOP, then.
Yeah. Can you not correlate the increased IOP because of the post-operative inflammation rather than the steroid use? How do you differentiate both? IOP can also occur after cataract because of increased inflammation. That is an important cause also to consider. Yeah. should document in the slit lamp examination, like any flare and the cells. That will be there in all cases. Within a day, all cases will be there. So how do you differentiate IOP because of increased inflammation, IOP because of steroid use? It's important to differentiate. Thank you so much.